Welcome to this explainer. Look, if you're an emergency medicine resident gearing up to absolutely crush your postgrad board exams, you are in the perfect place. Today, we're taking Tintinalli's Chapter 287 on acute agitation and transforming it into a high-yield, purely visual translation. We are going to lock down exactly what you need to know for test day and, honestly, for your very next shift.
Picture this scenario. A patient bursts through the doors. They're combative, yelling, just completely out of control. So, what's your immediate priority when that +3 agitated patient arrives? Your gut reflex might be to jump straight to heavy chemical sedation, right? Or maybe physical restraints. But as we're going to see today, those default assumptions, they might not just cost you points on your boards, they could actually be super dangerous for your department. Let's look at why.
Okay, first things first, let's actually define the threat we're dealing with. Agitation is not just a violent patient. It's formally defined as a temporary disruption of the typical physician-patient collaboration, which has unintended consequences for the staff or other patients. See, the crucial takeaway here is that it's way broader than just violence. Because once a patient actually turns violent, man, your options drastically shrink down to physical restraints and forced meds. We've got to treat this early, mainly to protect our highly vulnerable nursing staff. This definition, that's your trigger to act proactively. To help you master all this dense textbook info and reduce your cognitive load, here's a roadmap. We'll hit safety and initial approach, grading and verbal de-escalation, the treatment algorithms, antipsychotics and ketamine breakdown, restraints and special populations, and finally, a high-yield exam review. Let's jump right in. Section 1, Safety and Initial Approach. Before you even think about pharmacology or drawing up meds, you have to secure the environment. So your core best practice foundation really comes down to this fundamental 7-step checklist. Number 1, keep safety in mind. Put them in a prepared room away from sharp objects before they even get there. 2, attempt verbal de-escalation for absolutely everybody. 3, employ a show of concern, bringing in visible security if things escalate. 4, always treat medical problems first. 5, use restraints sparingly. 6, target the cause, using oral meds if you can. And 7, literally underline this for your boards. Second-generation antipsychotics are your first-line agents in most situations that don't involve alcohol. Seriously, lock that one in. All right, Section 2, Grading and Verbal De-Escalation. The room is safe, so how do we objectively measure what's happening and talk them down before turning to medications? To get the whole medical team on the exact same page, we use the Sedation Assessment Tool, or SAT. It's a scale that goes from +3, that's your combative, violent patient with those loud outbursts, all the way down to -3, where they have zero response to stimulation. Right in the middle is 0, meaning awake and calm. But here is the major high-yield fact for your exams. Medication is typically given at an SAT score of +2 or higher. That's that very anxious and agitated state, assuming, of course, they haven't been calmed down by verbal techniques yet. But hey, before drawing up those meds, lean heavily into the 10 principles of verbal de-escalation. We're talking respecting personal space, avoiding being provocative, and establishing concise verbal contact. You really want to identify their wants and feelings, listen closely, and agree where you can, or, just agree to disagree. From there, lay down the law to set firm limits, offer them some optimistic choices, and always debrief. I know pacing through these tactics might sound basic, but mastering this, it often prevents the need for IM injections entirely. It's a real game changer for helping the patient regain their own control. Moving right along to Section 3, the treatment algorithms. When talking it out just isn't cutting it, it's time to bring in the medical heavy hitters. Now, looking at these standard agitation algorithms, yeah, it's a lot to digest. It's like a giant puzzle. But look at the absolute first step across the entire board. You have to identify and correct any underlying medical condition. Honestly, it doesn't matter how agitated they are. An underlying medical cause takes absolute priority before you even think about throwing antipsychotics at them. So our approach completely splits based on what's causing the agitation. On the left side, if the patient is intoxicated with a CNS stimulant, you want to avoid benzodiazepines if at all possible. Your ladder here relies on first-generation antipsychotics, specifically haloperidol, starting oral and then moving to parenteral. But on the right side, for CNS depressants like alcohol, the whole playbook changes. Here, you're going to start with oral second-generation agents, and your parenteral fallback involves first-gen paired with benzos. It is a completely different pathway. And it gets even trickier with complex or undifferentiated patients. If the agitation is linked to delirium, again, you have to avoid benzos. You'll use a 4-step ladder moving from second-gen agents down to low-dose first-gen. But contrast that directly with the right side. If you suspect alcohol or benzo withdrawal, oral or parenteral benzos become your absolute first-line treatment. So for test A, keep this straight. Delirium means dodge the benzos. Withdrawal demands the benzos. Okay, section 4, antipsychotics and ketamine breakdown. Let's dive into the specific pharmacology and some critical safety warnings you absolutely need to know. Let's look really closely at these numbers because this is pure board exam gold. Check out the second-generation agents. Olanzapine has a max dose of 30 milligrams and a super long half-life of 21 to 54 hours. Ziprasidone maxes out at 40 milligrams with a much shorter 7-hour half-life. Neither of these is FDA approved for IV use, by the way. But look at the bottom row, haloperidol. This one carries a literal FDA black box warning for IV use, and its total daily dose should never exceed 100 milligrams. Plus, continuous cardiac monitoring is absolutely vital here if they're on any other QTC prolonging meds. So, the golden rule when dosing any of these medications is this: your goal is calm, but not sleep. You've got to emphasize this core principle in your practice. Why? Well, because sleeping patients generally cannot be evaluated by you or the nurses for disposition. If they are totally snowed, you can't move them and their length of stay just skyrockets. 39%. Let that sink in. Now, ketamine is sometimes brought up for excited delirium syndrome, usually at 4 to 5 milligrams per kilogram IM, but honestly, its use for general agitation isn't super well validated. In fact, one pre-hospital study showed that a whopping 39% of patients given 5 milligrams per kilogram of IM ketamine ended up needing ED intubation as soon as they arrived. On top of that, it causes severe hypersalivation and totally knocks the patient out, so they can't participate in their own care. All right, Section 5, restraints and special populations. We're moving into the absolute highest risk scenarios in the emergency department. We really need to talk about the restraint paradox. A restrained patient is often assumed to be safer for staff than an unrestrained one, but actually, this may not be true. The reality is, most injuries to both patients and staff happen during restraint episodes. Restraints bring massive legal implications, they drain a ton of ED resources, and one study even showed restrained patients stay 4.2 hours longer in the ED. They are an absolute last resort, only to be used after verbal de-escalation has totally failed. Now, what about special populations? For pregnant, elderly, and pediatric patients, non-pharmacologic approaches are almost always your first go-to. If you absolutely need meds, second-generation agents are preferred over first-gen. And for your exams, definitely memorize this rule. For the elderly, treat the underlying cause. Low-dose haloperidol or second-gens are okay, but you must avoid benzodiazepines and antihistamines. Those are strict no-goes for that demographic. Almost done. Section 6, High-Yield Exam Review. Let's do a rapid-fire recap to cement this for test day. Okay, let's fire through the high-yield stuff. For your exams, remember the core sequence: safety first, then verbal de-escalation, then meds, and restraints only as a last resort. Your SAT medication trigger is +2 or higher. Haloperidol has a strict max of 100 milligrams a day, and IV use is off-label with a black box warning. Ketamine? Not really well validated for general agitation. And lastly, second-generation antipsychotics are your absolute first-line choice when the agitation has a psychiatric origin. So, as we wrap up this explainer, I want to leave you with a thought. Are our default chemical and physical restraints truly making the emergency department safer, or are they just shifting the risk? By leaning into verbal de-escalation and using targeted etiology-specific meds based on these algorithms, you're not just practicing better medicine, you are actively protecting your patients and your team. Thanks for hanging out with me for this explainer. Keep this structure in your head and go absolutely crush those board exams.